Everybody, and thank you for joining me for my journal club assessment. I will be discussing an article in relation to monkeypox, and on my title screen you can see a picture from an electron microscope of monkeypox virus particles from a human skin sample. Before we start discussing the article, I'd just like to go through some established information known about monkeypox. It's a zoonotic disease caused by an orthopox virus, first diagnosed in the Democratic Republic of the Congo in 1970 and then spread to other regions of Africa. Cases are now emerging outside of Africa. Cases are increasing in both endemic and non-endemic countries. Incubation period is up to 21 days and usually presents with a prodromal phase of a headache, fever, back pain, muscle aches, and lymphadenopathy, followed by a centrifugal synchronous rash that progresses to macules, papules, vesicles, and pustules before crusting over and peeling off over a period of 2 to 3 weeks. It's transmitted through contact with infected animals, contact with infectious rashes or lesions, formites. So this includes contaminated clothing or linens that have infectious skin particles. If shaken, these particles can disperse into the air and be inhaled, land on broken skin or mucosal membranes, and lead to transmission and infection. It's also spread through droplets, and airborne transmission can occur with prolonged close contact. Vertical transmission also occurs from mother to child. The case fatality rate depends on the clade. The Central African clade is 10.6% and the West African clade is 3.6%. Here are some pictures of typical monkeypox presentations from the Democratic Republic of Congo from 1997. The first picture is of a young boy with a maculopapular rash, and the second picture is of an adult's palms with a maculopapular rash that's starting to crust over. So the journal article I have selected for presentation is the demographic and clinical characteristics of confirmed human monkeypox virus cases in individuals attending a sexual health centre in London, UK. An observational analysis by Griffith et al. And it was published in the Lancet Infectious Diseases Online on the 1st of July 2022. This article noted the increasing monkeypox cases in the UK among patients attending sexual health clinics, with no apparent epidemiological links to endemic areas. As part of the local service evaluation, the authors examined the demographic and clinical characteristics of patients diagnosed with monkeypox attending sexual health clinics in London. So the relevance of the paper to my area of practice. So I'm a public sexual health nurse and I work within prisons in New South Wales. So it's relevant because monkeypox was not observed in Australia prior to May 2022. And as of the 1st of September 2022, we've now had 124 cases of confirmed or probable cases in Australia, with 48 of those being in New South Wales. Prisons are high-risk environments for infectious disease outbreaks due to high-density housing, overcrowding, shared living facilities. So we have a number of facilities where patients live in dormitory-style accommodation. Patients constantly move between jails and into and out of the community. Our population also has a higher burden of underlying health conditions, making them more vulnerable to infection. Monkeypox has been suggested to be sexually transmitted, and this is important for my area of practice, as patients in Australian prisons test positive at significantly higher rates for STIs such as chlamydia, gonorrhea, and syphilis than the general population. In 2016, prisoners were 10 times more likely to be positive for chlamydia, 15 times more likely to be positive for gonorrhea, and 270 times more likely to test positive for past or current syphilis infection. So the article looked at the demographic, travel, sexual, and clinical characteristics of patients with confirmed monkeypox virus attending sexual health clinics in London. So they wanted to know who monkeypox was infecting. They wanted to know if they had epidemiological links to endemic countries or if local transmission was occurring. And they wanted to see if there was a potential novel route of transmission and if monkeypox was having a different clinical presentation to historically noted. So the importance of the research question. So monkeypox is a high consequence infectious disease. Identification of outbreaks outside endemic countries requires investigation. It's important to identify at-risk groups so that education can be targeted, to identify if there are changes in the modes of transmission, again for targeted education, but also for infection prevention and control strategies. We may need to update case definitions if there is a different clinical presentation to the established definition, and monkeypox needs to be considered in the differential diagnostic process. So the authors conducted a literature review using PubMed to compare their study results with existing knowledge. They did a retrospective observational analysis of 54 patients with PCR-confirmed monkeypox from the 14th to the 25th of May 2022, who attended one of 4 sexual health clinics in London. Data was obtained through electronic patient records and sexual health dashboard. Demographic, travel, sexual health history, and clinical presentation were analysed. STI results were reviewed, and the authors also described how they managed suspect monkeypox cases using appropriate transmission-based precautions. So they put information out on social media and the sexual health website for patients to contact the clinic prior to presentation if they were experiencing monkeypox symptoms. They were phone triaged and, if deemed clinically appropriate, was sent to a specific hub set up to manage suspect monkeypox cases with appropriate infection prevention control measures and appropriate PPE. Healthcare staff wore contact, droplet, and airborne precautions, and the establishment of the hub also prevented suspect monkeypox cases from mixing with other patients. So the results. So they found no epidemiological links to West or Central Africa. All patients identified as men who had sex with men. Over half reported more than 5 sexual partners in the 12 weeks prior to diagnosis. 1 in 4 had a concurrent sexually transmitted disease. 24% were living with HIV. 9% required admission into a hospital for secondary cellulitis or pain management, and no deaths were recorded. So the clinical presentation, so 18% had no prodromal symptoms, which is different from the historical cases of monkeypox. 67% reported fatigue or lethargy, 57% reported fever, and 55% had lymphadenopathy. Only 4% presented with a skin rash. All patients presented with skin lesions. 94% were anogenital, and 31% had blistering localized to only one anatomical site. Only 28 presented with the classic monkeypox skin manifestations on 3 or more sites. So the authors took some photos to help clinicians be able to identify monkeypox lesions. So this is a single umbilicate pustule lesion on a leg. And as you can see, this presentation is very different from the pictures I showed before from the Democratic Republic of Congo. Here are some more pictures as well. So the first one shows a coalescing lesion on a penis, and the second one shows multiple umbilicate pustule lesions on a penis. The next slide shows the progression of the lesions. So the first slide shows an ulcerative lesion on the perianal skin, and it progressing to a large coalescing ulcerative lesion. So the importance of this study, so the current outbreak outside endemic countries appears to have a different clinical presentation and impact a different demographic than historically. This research established local transmission, demonstrated an atypical presentation, identified men who have sex with men as a population affected by the current outbreak, identified high incidence of concurrent STIs, and described sexual contact as a novel chain of transmission. This study was valid because it had a literature review that was attended prior to the study. This provided context, informed their methodology, and avoided them duplicating work already attended. The retrospective data collection reduces the chance of bias as the research question and outcomes were not known at the time of the collection. They used a good sample size. Of the 54 patients that they identified, that was roughly 60% of the monkeypox cases reported in UK and 21% worldwide from the current outbreak as of the 26th of May 2022. Now, the World Health Organization has actually updated their case definition, removing the need for prodromal symptoms and including single or multiple lesions in the anogenital region. The WHO interim guidance also now suggests monkeypox testing for patients with clinical signs who identify as men who have sex with men or report high numbers of sexual partners in the 3 weeks prior to symptom onset. This study did, however, have limitations. Retrospective studies can only analyze the data already collected. This does not allow for control over the type or quality of data collected. Relevant data may also have been missed and not collected, such as the length and extent of exposure to possible sources of infection. Selection bias was present as they only examined data from patients attending sexual health clinics. This group may be too similar with regards to their exposure and risk factors. Current health promotion is also aimed at men who have sex with men, and thus men who have sex with men are more likely to present for monkeypox testing than other groups. And patients who do not identify themselves at risk of monkeypox might not attend a sexual health clinic for assessment. The hospitalisation rates might be inaccurate representation as well, as patients who are systemically unwell with severe symptoms are more likely to attend a GP or an emergency department than a sexual health facility. These results are applicable to the wider population because monkeypox is increasing in the Australian population. And patients may not attend a sexual health service. They might go to a GP, a genitourinary clinic, or an emergency department. Patients with suspected monkeypox need contact, droplet, and airborne precautions to prevent transmission. So clinicians need to be aware if they do have a patient with suspect monkeypox to implement the correct transmission-based precautions. Patients may present with atypical symptoms, and clinicians need to be vigilant for and have monkeypox in mind as a differential diagnosis, particularly in men who identify as men who have sex with men. While monkeypox in this article appeared to be more mild than in Africa, 9% of patients still required hospitalisation for pain management or secondary cellulitis, so it can be a serious disease in this setting. How will I use this study to inform my practice? So I will include monkeypox in my differential diagnosis, especially when dealing with anogenital lesions. I will have a high suspicion in men who have sex with men and patients with multiple sexual partners. I will be wary to use appropriate transmission-based precautions when assessing a suspected monkeypox case, and we'll need to target education and prevention strategies aimed at men who have sex with men. And that is the end of my presentation. Thank you very much. I'll just go through some of the references. Thank you very much.